Okay. Bismillahir Rahmanir Rahim. مساكم الله بالخير. Thank you very much for your attendance, and we have a lot of attendance. Today we have something about the hypertension, but it is totally different from the usual lectures of hypertension. The reason is that we know, all of you know, that we need to control the hypertension because the blood pressure is harmful. We know that. We know that we can use diet and any antihypertensive medication to control the blood pressure. We know that. But today, what we need to talk about is we'll take the hypertension in terms of quality control. How optimum and how good quality control for blood pressure. So tonight we are going to talk about the optimum and the quality of control of hypertension. You can control hypertension by alpha blocker, for example, or beta blocker or whatever, but is that a good quality? This is an important question. And that's what we are going to address. In fact, the whole problems why we are not reaching the hypertension goal, because there is a lot of problems related to our attitude, related to the guidelines in the beginning, and now related to the inertia of the physician. The inertia of the physician means that the physician doesn't want to change the medication. And then he will bring excuse for the reason why the blood pressure in the office is high. He will bring the reason and excuse, and he will not change the medication. This concept is not acceptable. Today, we have two eminent speakers. They are always, if they start talking, you don't want them to stop. But tonight, we have to ask them to be within the time limit. Unfortunately, we have already late. First of all, Dr. Ashraf Sha'ban, he will talk after my talk. He will talk about which combination. First of all, is the combination indicated? And then if the combination indicated, what combination we should choose? Because today we are talking about the quality of treatment. So the quality of treatment, there has to be a good combinations with evidence-based medicine. Then after that, Dr. Abdul Maqsood will talk about an example of utilization of the best combination as per evidence of the guideline, and he will demonstrate it in a case history. And I'm sure you will enjoy, and we have a lot of participants tonight. So first of all, I will talk about the single pill combination. Is it the first step or the second step? Okay, this is the first objective that we are going to talk about, the difficulty, why we are not reaching the goal. Then how important to control the pressure, and when. Is it early control of blood pressure, or at any time you need to control the blood pressure? At third point, we are going to discuss the principle of combination therapy, and then we will prove for you that the combination strategy is the best. I have nothing to disclose by these lectures except that we are taking some honorarium from the company. Otherwise, we have no conflict of interest. You can see in this slide that the number one from the 10 killer in the world is hypertension. And that's have been proven in 2002. So hypertension is number one cardiovascular killing. Why? Because that uncontrolled blood pressure will increase the coronary artery disease by 3-fold, increase the stroke by 7-fold, increase heart failure by 3-fold, and increase peripheral vascular disease by 3-fold. So the hypertensive uncontrolled blood pressure going to increase the cardiovascular outcome and the mortality. So that's very important step. Secondly, how to measure the blood pressure. Just quickly, I want to tell you, we are not anymore using the sphygmomanometer, the standard sphygmomanometer, because most of the trial, they have used the Dynamap or this devices, the electronic device. When you choose the type of electronic device, you need to know how to use that electronic device in order to get the proper blood pressure. Why we are telling this? Because we want to standardize the outcome. We want the patient to understand how to use it. And we need to tell you that there is a monitoring, home blood pressure monitoring, which is very important becoming nowadays, and the 24-hour blood pressure monitoring, and the office blood pressure monitoring. So the device is important, and from time to time, you might need to control it with another device. So the talk about this single pill combination as the first strategy, we are going to utilize the 2018 guideline from the European and European Hypertensive Society and the European Society of Cardiovascular Disease. So these two society has made a lot of changes from 2013 to 2018. And this is the guideline from 2018 from the European Society of Cardiology. And you can see, first of all, there is an optimum blood pressure control. Optimum means the blood pressure less than 120/80. Means that the blood pressure 120/80 is the optimum. So if you want your patient to be optimum without any other side effect, without any problem, your optimal blood pressure will be 120/80. Is that the standard of care? Yes. But whenever everything is possible, because we are talking about optimum and essential. The essential care is the care which reduces the blood pressure to a reasonable level without the standard of the optimum. The optimum is less than 120 or at least 120/80. Now the normal blood pressure from 129 to 100, from 120 to 129 systolic up to 180 to 80 for diastolic. So this is normal blood pressure, acceptable to be normal for variable of patients, including the age, including the young age group, and so on. We are having here something called high normal blood pressure. This is a high normal blood pressure when you need to intervene if you are looking for optimal medical therapy. If you want to optimal medical therapy, then you have to go to the high normal and start control or intervening by dieting, by drugs, whatever. And then once you are in grade 1 and grade 2 and grade 3, you are mandatory to control the blood pressure. So now in the essential, you might not need to look into this high normal if you want to essential control. Means the essential control, there is a limitation, cost, limitation of access to medication, access to the doctor, etc., and or peripheral hospital or poor countries. But if you are talking about the standard of care in a good country, then your high normal blood pressure, you should intervene. And the combination can be used over here. We have the combination when you can use one drug, small dose, and the second drug, the small dose, and you can build up your combination. For example, here, Britrax, for example, the Britrax, small dose of diuretic, small dose of ACE inhibitor, they are doing the job in such condition. If the diet alone is not, and we know Saudi populations and the Gulf countries, they are not looking for the diet to control their weight and to get control of blood pressure. So this is the two essential and optimum, as we have said, and we have defined it. The optimum, it should be to the standard of care in the best circumstance. The essential to be anywhere in the world, anywhere. So the Hypertension Society have shown, the International Hypertensive Society showed that the blood pressure 130/80. So 130/80 for them, less than that is hypertensive. And it should be normal. But we said, if you reach 130 for optimum control, you have to treat. So that's the difference between the International Society of Hypertension and the European Society of the Hypertension on the other side. The European Society of the Hypertension, they consider this hypertension and you have to treat. Meanwhile, the international is not. The reason is international looking for the whole globe, where like Somalia or like Yemen, where the very poor access to the medical health, you need not to be very tight or to be optimal. So that's important. And then the office blood pressure 140/90, that's the standard of the European Society of Cardiology. Home blood pressure 135/85. Then the blood pressure of 24-hour monitoring should be 130/80. This is where below which is required, above if you have to treat, whatever the mode of treatment you are going to use. And this is confirming that the blood pressure of more than 140 consider hypertension, but in the optimal care, in the young patient, you need to come to 120. And the guideline will show you later how different is the guideline approaching this target. Then what is the blood pressure target? The blood pressure target is here, look. I want you to consider, I want you to consider on this shape, the Canadian Hypertensive Society. They said that the blood pressure should be less than 120/80. Why? because they are advanced country. They have a healthcare is different from the all world healthcare. They provide the patient with the best healthcare available. That's why they consider their blood pressure of less than 120/80 to be the control blood pressure. For the others, for example, American College 130, European 140, about office, nice. The British 140, Korean 140, the SHIB 120/80, and because we are part of the third world, we don't have a very good system of healthcare. We accept 140 to the 140/90 to be the cutoff for treatment of hypertension. But if you are in a center where you want to consider yourself as an optimum, then your target of 120, less than 130, and around 120. So this is important to understand the target and different guidelines. But unacceptable to leave the patient with more than 140/90 blood pressure. Then are we as a physician controlling the blood pressure? In fact, no. Only worldwide, 15 to 20% of the hypertensive patient, they are controlled. 70% they are not controlled. Then that's why the cardiovascular outcomes is more. The cardiovascular stroke, heart failure, death is more because your blood pressure, 70% they are not reaching the target. Now the target has been changed. In the previous, we said, okay, diabetic, he should be less than 130/80. Now 130/80 or less is for all, not only for the diabetics. The only concern will be with the elderly when you have to be careful to utilize the treatment of control hypertension. So this is where the worldwide, you can see from Italy up to England, 70% at least, they are not reaching the goal. And this study has been recently addressed in the 2018 as well. So they know that we are not doing a good job, and that's why the outcome is not good, because you have patients with a stroke, you have patients with heart failure, etc. So why we are not reaching the target? Why we are not reaching the target? Because insufficient national advisory healthcare policies. So the policy of the healthcare is not equal in all countries. Very good, number one. Number two, poor potential compliance and adherence from the patients. The patient who doesn't like to take pill. Then the reluctance of the physician to modify the treatment with the patient visits. And this is what we call therapeutic inertia. Therapeutic inertia is the patient reluctant, the physician is reluctant to change the medication for the patient's sake. And then, as I told you earlier in the beginning, that he will look for reasons why the blood pressure is more than the target he wants. Because he will say that the patient under stress, the patient had to take coffee, the patient smoke, etc. So please don't talk about the patient. Once you have the blood pressure is uncontrolled in the office, you have to be aggressive. And the limit for you 120 down and 140 up. So this is the treatment for hypertension. You can see in this one, there is no single drug will control the blood pressure appropriately. So in the past, we used to have the strategy of single pill, increasing the dose, single drug, and increasing the dose. Then some people adopted the drug of the sequential strategy, means stop this drug, try another drug with the maximum dose. This sequential has not been recommended by any part of guideline, never recommended, but the physician adopted it. I will change, for example, the beta blocker to the calcium channel blocker, but again with the single drug. The single drug never control the blood pressure. You have to go for combination or more than one drug. And this is the European Society of Cardiology of Hypertension and Cardiology of the European Society of Cardiology. They said the initial therapy should be a dual combination. Dual means that calcium channel blocker, ACE inhibitor or ARB and calcium channel blocker in a small dose or in higher dose. This is the first combination. Might ask why ACE inhibitors, not why the word ACE inhibitor started before ARB, because ACE inhibitor has a lot of advantage on top of ARBs. ARB is alternative if there is a side effect from the ACE inhibitor. Then if the patient does not reach the goal, you might add the combination of ACE inhibitor, calcium channel blocker, plus diuretic. So 3 combinations. So you can appreciate the first combination, ACE, ARB, or calcium channel blocker, or diuretics. Is that the calcium channel blocker or diuretic with ACE inhibitor, are they okay? That's the talk Dr. Sha'ban will tell us later on, are they equal or no? But still, I am going to tell you that if you have a resistant hypertension, despite the 3 combination of ACE inhibitor, calcium channel blocker, and diuretics, you should go for a resistant hypertension, and don't forget spironolactone and the 4th drug as a beta blocker. But here, look at this, that you are going to reduce the blood pressure by 20 millimeter mercury, you are going to reduce the outcome by 50%. So which combination? The combination ACE inhibitor with ARB, or with the ACE inhibitor with diuretics, or ACE inhibitor with calcium channel blocker. This is the accomplished trial. It showed you that the better control will come with ACE inhibitor and amlodipine compared to ACE inhibitor and diuretics. And further explanation will be by Dr. Ashraf Sha'ban. But I want to tell you from the beginning that the diuretic is not the choice, in fact, compared to the calcium channel blocker, according to the study. Why? Because the uses of calcium channel blocker with the ACE inhibitors, it gets a very early blood pressure reduction. And in value trial, the early reduction of blood pressure is very important to reduce the outcome and the mortality. Then this is the slide of the advantage of a single pill combination. I don't want to read it all for you because of the sake of time. And we need to know that the single pill combination is the way to go from the beginning and then up to now. What is the major change? And you can see that in 2018, all the recommendation, initial combination considered to be strong recommendation as an initial combination. The reason why, you will get adherence from the patient, and you all overcome the inertia of the patient, the hesitancy, inertia of the physician, the hesitancy of the doctors not to prescribe the combination. And again, this is emphasizing the same thing, that between the essential and optimal is 120 optimal and essential 130. I will recommend you that this is, you can take the references, the compendium on the pathophysiology and treatment of hypertension, 2-drug combination as a first step antihypertensive treatment, published in 2019. And this is published by Dr. Menshia, is the president of the European Hypertension Society. And it is recent. It is a good review and summary. And I can just give you a capsule of what he found. Number one, look, that the monotherapy and then the follow-up with monotherapy, this is, by the way, 400 patients, almost it started with 400, then 800,000. 800,000. This is the population of a whole city, like Framingham. So they found mono and mono, there is no change. The mono starting, then follow up by combo is the same. The combination followed by monotherapy is better. But if you combine from the beginning and you continue combination, you have a very good outcome for control of blood pressure and for control of the side effect or the outcome of the events, stroke reduction. This is what hospitalization, etc. Look at the second paper, the second graph. The cardiovascular events is reduced with the monotherapy with control, and then coronary heart disease, stroke, heart failure, and atrial fibrillation, all of them reduced if you start combo. Means started with combination, a small dose, follow up of your patient with a higher dose of combination, and then you are going to reduce all of those events, including hospitalization for heart failure, coronary artery disease, stroke, and atrial fibrillation. So that's important. And if you go back, you want to go back for the references, I will recommend it to all of you. It's very informative and recent, and you can get a look at it. What is the home message we'll give you? You have to reach the goal. How? You have to combine very early. Why? Because you want to reduce the blood pressure very early, and then you want to overcome the compliance of the patient by single pill, and then you want to overcome the physician inertia. The calcium channel blocker and the angiotensin converting enzyme inhibitor combination, it is available in small dose and in higher dose. Britrax, Britrax, then you have Perindopril and calcium channel blocker. This combination, all they utilize ACE inhibitor, and we said that ACE inhibitor is better than all ARB because it is an important drug, and then particularly the Perindopril has a tissue ACE inhibitors, and I will recommend all of this. And then now I will minimize my slide. Dr. Ashraf will talk about the selecting which combination is the best for our patient. Please, Dr. Ashraf. I will stop sharing myself.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. Thank you, Dr. Mustafa, for your kind introduction, and I would like to thank all the teamwork of Servier Pharmaceutical Company as well as the Saudi Heart Association for giving me the opportunity to interchange our knowledge as regard single pill combination are all equals. Thanks to Dr. Mustafa, he had paved the way for me and facilitate my mission to introduce my talk. Actually, my colleagues...
Dr. Ashraf, can we see your slide, please? We are not able to see.
Okay, I will share again. Let us talk about hypertension. As you have mentioned, Dr. Mustafa, this is #1 risk factor for cardiovascular mortality. And by the year 2025, around 50% from Saudi population will be hypertensive. This is as regards the prevalence. What about the control? 67% are still far away from the control, and that is why our first choice matter as regards treatment of hypertension. But blood pressure lowering is designed to be difficult. There are certain reasons for that. Blood pressure is maintained by multiple pressure systems designed to resist blood pressure lowering. Redundancy, inhibition of one system could activate another pressure system. Structural changes, a small and large artery maintains peripheral resistance and systolic pressure resisting blood pressure control. This slide, there are different players in the pathophysiology of hypertension. We have the sympathetic system, renin-angiotensin system, total body sodium. In different patients, there are different contributions in the evolution of the hypertension. In order to succeed, we should gather each weapon to tackle each pathogenetic arm in order to succeed and bring the patient into control. Why do we fail in hypertension management? There is actually a problem of underestimation of the challenge, not taking into account the human factor, continuation of the old strategy, non-adherence to antihypertensive medicine in the real world according to the number of medicine. We have found in this study that 24% of the US patient take less the medication than is prescribed. If we prescribed, for example, for 100 patients, treatment filled in 88, taken by 76%, and only 46% are well controlled. Medical inertia is a challenge when moving from 1 to 2 drugs. And in the same time, all of the guidelines recommend prompt treatment and bringing the patient into control. The aim for blood pressure control within maximum 3 months. So the time factor must be respected. You have mentioned, Dr. Mustafa, as regard the new strategy in the management of hypertension, and RAS are cornerstone in hypertension management. Monotherapy now is for only mild cases, and single pill combination is strongly endorsed as a first line. Only monotherapy when there is low risk grade 1 hypertension or frailer elderly patient. But the rule now and the new strategy, initial therapy, dual combination by ACE, and if not tolerated, by ARB plus calcium channel blocker or diuretic. If not controlled, I will add a diuretic, triple therapy, or Step 3 is a resistant hypertension. If I used at least 3 medication, one of them is a diuretic, and I could not reach to the target, I will add another agent like spironolactone, alpha blocker, and consider to check for resistant and secondary hypertension. The treatment strategy for uncomplicated hypertension by different societies, the ESC-ESH in 2018 and the International Society of Hypertension recommended the initiation treatment with the use of 2 drugs, as you have mentioned in a professional way, Dr. Mustafa. Why the guidelines encourage starting treatment with combination therapy for better blood pressure control, faster blood pressure control? You have mentioned, Dr. Mustafa, in the value trial, and the onset of reduction by amlodipine in comparison to valsartan, it differs in the outcome. Less variability in response. Everybody is responding for the combination therapy, safe and well tolerated, fewer pills which encourage the compliance of the patient, 2 simple treatment steps, more than 80% are controlled. But how? How to select the single pill combination treatment? The ideal core component of single pill combination, useful in various clinical conditions, useful in different age groups, available in combination with several medication, available in double and triple combination, supported by the evidence-based medicine. Perindopril is one of the novel ACE inhibitors, and the pyramid of evidence-based medicine, starting from all the continuum of the cardiovascular continuum. We have the ADVANCE, the ASCOT, the Europa, the PROGRESS, all of these different stages, from subclinical to target organ damage. We have the evidence for Perindopril and its favorable effect on the subclinical and the clinical target organ damage. 2 corners of Perindopril-based single pill combination treatment in Saudi Arabia. We have Perindopril plus Indapamide, as you have mentioned, the Pretrax and the Bipretrax, and the Perindopril plus amlodipine, which actually is a happy combination between novel ACE inhibitor and the novel calcium channel blocker. Again, which Perindopril-based single pill combination and for whom? Let us think about that. The 2 corners of Perindopril-based single pill treatment in Saudi Arabia, we have said Perindopril and amlodipine. And I have mentioned that this is actually a happy combination in the regard of management of hypertension. As regards the molecular synergy, actually, my colleagues, if we want to treat hypertension, we are not only looking to the figures of reduction, the number of reduction, but we are looking for the clinical outcome. And this happy combination have some sort of molecular synergy. For the ACE inhibitor, which is, we have found the endothelium and the ACE inhibition by Perindopril leads to upregulation of bradykinin, increase in the nitric oxide synthetase, induction of relaxation and vasodilatation. This is one pathway. We have another pathway. By antagonizing angiotensin II, it decreases the contractility of the smooth muscle cells. In the same time, the other partner in the happy combination, which is amlodipine, which leads to reduction in the cytosolic calcium leads to prevention of contraction and vasodilatation. In simple way, we can say that Perindopril is acting on the endothelium and as well as on the smooth muscle cells, and amlodipine leads to vasodilatation and acting on the smooth muscles leads to reduction of the blood pressure. This was translated into clinical synergy. We have the evidence for Perindopril inhibitor as regards the coronary artery disease in Europa trial and in stroke in progress, and also the amlodipine. This is gathering of benefit. Both of them decreases the risk of coronary artery disease as well as the stroke. The addition of Perindopril to amlodipine lowered blood pressure more than atenolol-based regimen and maintained it over the years. There was a significant reduction in the systolic blood pressure as well as the diastolic blood pressure in comparison to the beta blockers. Very important point, effective control of the bedtime blood pressure from the baseline in the long-term follow-up with Perindopril amlodipine. We have found here the beta blocker and thiazides without reduction in the bedtime blood pressure, but the happy combination of amlodipine and the Perindopril succeeded to reduce the blood pressure at nighttime systolic blood pressure. And here I would like to talk about dipping of the blood pressure. All of us, if we return to the College of Medicine, we have found that during sleep, the parasympathetic system takes the upper hand, the sympathetic system goes down, parasympathetic system leads to slowing of the heart, vasodilatation of the blood vessels. So there is lowering of the blood pressure during sleep. But certain patients, like for example diabetics, this dipping does not occur and we are called them non-dippers, and this puts them at the risk of cardiovascular morbidity and mortality. Again, Perindopril corrects this problem by induction of the dipping of the blood pressure during night. This slide shows the relation between the large arteries and the microvascular remodeling. Let me explain very simply. Actually, the cardiac output, the first, it passes to the aorta. The aorta is elastic organ, and this is called buffering system. When the cardiac output pushes the stroke volume into the aorta, the elastic aorta dilates in order to does not transmit this high blood pressure to the microvascular vasculature. In elderly patient, in hypertensive patient, in diabetic patient with age, obesity, diabetes, dyslipidemia, the aortic stiffness occurs due to oxidative stress, inflammation, protein cross-linking. So the buffering system of the aorta is lost. The high blood pressure of the stroke volume does not minimized by dilatation of the aorta, and the stiff aorta directly transmit this high blood pressure to the microvascular, which leads to tissue damage and loss of autoregulation, leads to increased wave reflection, microvascular rarefaction, and this is a vicious circle. Again, Perindopril has a special benefit in the blood vessel remodeling, in the elasticity of the aortic, in reduction of the spasticity of the aorta. That is why we are gathering the benefit from this novel ACE inhibitor. Another point, blood pressure variability. The less blood pressure variability leads to a better clinical outcome. This is lower of the blood pressure variability and low risk in comparison to more blood pressure variability. And we have found that amlodipine has its beneficial effect on the lowering the blood pressure variability, and in the same time, Perindopril, due to its long duration of action, due to action on the tissue ACE, due to the avidity to the receptors, and it slows and minimizes the blood pressure variability. This is a gathering of benefit. Perindopril and amlodipine provides a sustained blood pressure control over 24 hours. This is Coversil and amlodipine, and that is why it will cover the critical early morning hour, which are the critical time for hypertensive patient for death. So from the ASCOT trial, we have gained the clinical benefits by combination, happy combination of amlodipine and Perindopril as regard non-fatal myocardial infarction and as regard silent myocardial infarction and stable angina, peripheral arterial disease. All of these are better for the happy combination of amlodipine and Perindopril. And here I would like to explain. I have mentioned that Perindopril acts on the endothelial dysfunction, on the relaxation of the smooth muscle cells, on the blood vessel remodeling, and the decrement of the collagen and the fibrosis, and that is why increases the capillarity of the myocardium, decreases. All of these are gaining benefit in clinical outcome. As regards the cardiovascular events and the procedures among subgroups in the ASCOT trial, we have whatever the pathological condition in diabetes, in obese, in metabolic syndrome, in patient with renal impairment, in elderly patient with left ventricular hypertrophy, vascular disease, a smoker, we are gaining a striking benefit by happy combination of Perindopril and amlodipine. What about the uncomplicated patient and for whom this happy combination? Uncomplicated and complicated hypertensive are a candidate for that. All cardiovascular risk groups, all age categories are candidate for this happy combination. And we have, again, in order to finish my talk, Dr. Mustafa, in the proper time, as you asked us, Perindopril and Indapamide, another happy combination. And we have found in the ADA guidelines in 2017, the combination drug therapy, the blood pressure arm of the advanced trial demonstrated that the routine administration of a fixed dose combination of the ACE inhibitor, Perindopril, and the thiazide-like diuretic, Indapamide, significantly reduced combined major microvascular and macrovascular outcome, as well as deaths from cardiovascular causes and the total mortality. And that is why they recommend the active blood pressure intervention arm, a single pill fixed dose combination of Perindopril and Indapamide showed a significant reduction in the risk of the primary composite endpoints and significant reduction in the risk of death from any cause and of death from cardiovascular causes. And from the advance, Perindopril indapamide reduces all-cause mortality in hypertension and in diabetes. And don't forget, my colleagues, that Perindopril reduces the new onset diabetes among patients with metabolic syndrome, and this is very important as regards the subclinical target organ damage. It decreases microalbuminuria, and the other partner as well, indapamide, has, in spite of the beneficial effect of Perindopril, it reduces microalbuminuria. That is why we are gathering benefit from two beautiful, happy combination. In the ADVANCE-ON trial, the sustained mortality reduction over 10 years was respected as regard all-cause mortality and cardiovascular deaths. So in conclusion, Mr. Chairman, hypertension is a major risk factor for mortality worldwide. Reduction in mortality is ultimate goal of the antihypertensive treatment. According to new studies and meta-analysis, ACE inhibitors significantly improve survival in hypertensive patients with cardiovascular risk factors. Benefits of Perindopril in combination with amlodipine or indapamide is strongly supported by strong evidence from large morbidity and mortality trials. And thank you so much.
Thank you very much, Dr. Ashraf, for this very comprehensive evidence-based medicine.
I will stop sharing.
ثروة كبيرة. Yeah, stop sharing. Thank you. ثروة كبيرة تعلمناها منك اليوم دكتور أشرف for very nice presentation and the التشويق في البرزنتيشن كمان. هذا talent عندك مميز ما شاء الله. We will keep the questions at the end, and now it is the time for Dr. Abdul Maqsood to share with us his cases, and this is just to implement or implications of the treatment or the best strategy to use for treatment of hypertension. تفضل Dr. Abdul Maqsood. Again, we will listen to very high caliber speakers, which are always fighting with him in a meeting. We are, fighting each other just for the sake of education.
Hello, assalamu alaikum.
Alaikum assalam wa rahmatullah.
Thank you so much, Dr. Mustafa, Dr. Ashraf, and I'd like to thank Saudi Heart Association for organizing this meeting. It was excellent meeting. Really, myself, I enjoyed the talk of Dr. Mustafa and Dr. Ashraf. And actually, you give me the railway for my case presentation. I will present only one case today.
Meanwhile, while Dr. Abdul Maqsood is trying to get the presentation, I will summarize for you what we have talked about, me and Dr. Ashraf, that we are all agreed that the blood pressure should be controlled in the first place. Secondly, how to control the blood pressure, it is depend on you, but there is something called optimal and something called essential. If you will go essential, use whatever the medication just to lower the blood pressure. If you will go optimal, you have to select the best for the patient. And according to the information available to us, that using a single pill combination from the beginning, number one, once you use the single pill combination from the beginning, you are going to have two advantages. In fact, three advantages. The advantage number one is that you are going to have the blood pressure reduced immediately. And this has an implication according to the value trial. Those whom reduce the blood pressure very early, they get the better outcome. Secondly, that the patient will be very compliant because he's using two combination and the blood pressure is controlled from the beginning. Three, the physician, if he is going to change, if in need of a change, he will go for the same combination, but he will increase the combination dose. Dr. Abdul Maqsood showed us that the Perindopril and then Indapamide, and he showed us ACE inhibitor and calcium channel blocker. And then if you have a patient with the blood pressure in the lower side or in the, who will need a small dose, you can go with the Perindopril and Indapamide. If the patient will need a very stronger dose, you can go to ACE inhibitor and calcium channel blocker. So this is how the single pill combination will help you. Third, in fact, fourth point, it will help you to overcome the blood pressure variability, which has been now explained very well by Dr. Ashraf. Dr. Ashraf said that two pill combination, the variability of the blood pressure will be overcome by two pills combination, by a single pill combination for the two drugs. The reason behind this, that the variability of the blood pressure is harm. It causes harm for the patient. Ready, Dr. Abdul Maqsood?
You can see the slide now?
We can see all the slides, but
Yes,
make it
yes,
make it
perfect.
على magnified, make it على الجلاس حق السلايد شو.
على السكرين شو.
Okay, now
Okay.
Dr. Abdul Maqsood will start his case. Good, Dr. Abdul Maqsood. تفضل.
Okay, again, sorry for this technical problem from me.
Perfect.
Yeah, again, thank you so much, Dr. Mustafa, Dr. Ashraf, for giving me the chance to share this session. Actually, give me the most important knowledge for my case. You make my job easy. So I will present a very interesting case, only one case presentation for hypertension. He is 45 years old, male, hypertensive since 2018. Recently, in 2020, he was presented to our outpatient department because he was worried about his high blood pressure. In 2019, he was advised to start lifestyle modifications and home blood pressure monitoring, and no drug therapy was initiated. Unfortunately, he is not compliant even to lifestyle change because of his commitments and lack of interest. The patient never checked his blood pressure because he is asymptomatic, and this is most probably common in most patients with hypertension. On examination, his body mass index 29 kilogram per meter square, his blood pressure mean of 3 reading in sitting position 154 over 93 millimeter mercury, his heart rate 68 beat per minute and regular. Apart from apical SC3, there is no any cardiac abnormality. His chest examination showed a normal finding. This is resting 12-lead ECG, and you can appreciate here from the ECG finding, it's fulfilling all the criteria of left ventricular hypertrophy according to Soklow criteria, Cornell criteria, Framingham criteria, and Romhill criteria. So he has a target organ damage in the form of left ventricular hypertrophy, which was documented by ECG. His lab test showed the following results: fasting blood sugar 92, serum creatinine 1.1, which is a little bit high, but the estimated glomerular filtration rate normal 95 ml per minute. His uric acid 6.2, sodium 140, potassium 4.1, and here the total cholesterol was 232 milligram per deciliter, normal triglyceride HDL 46, LDL cholesterol 161 milligram per deciliter, and he has all criteria for microalbuminuria. So this is a second target organ damage, which is microalbuminuria as a complication of hypertension. As Dr. Mustafa and Dr. Ashraf mentioned, the definition of hypertension according to the ACC/AH guideline, I will not go through. It was demonstrated well by Dr. Mustafa and Dr. Ashraf. Also, the European Society of Cardiology guideline using the office ambulatory blood pressure monitoring or even home blood pressure monitoring. All this was mentioned by Dr. Ashraf and Dr. Mustafa. Recently, the International Society of Hypertension 2020, they did classification of hypertension based on office blood pressure measurements, and you can appreciate here the normal systolic less than 130 and the systolic less than 85, high normal blood pressure 130 systolic to 139, and or diastolic blood pressure 85 to 89 millimeter mercury. Grade 1 hypertension 140 to 159 systolic, and or diastolic blood pressure 90 to 99. Grade 2 hypertension, systolic pressure equal or more than 160, and or diastolic blood pressure equal or more than 110. So this is very interesting slide according to the blood pressure measurements, which was published recently in the International Society of Hypertension 2020. And you can appreciate here from the picture that the patient should be back supported, and no talking during and between the measurement. And this is impossible to get it in our patient. All patients are talking during measurements, and cough to fit arm size, small, usual, and large, arm pair and not resting, and resting mid-arm at the heart level. And you can use, as Dr. Mustafa mentioned, validated electronic blood pressure device, no more mercury device used. And the place to measure should be quiet room and comfortable temperature, no smoking or coffee or exercise for 30 minutes before measurements, empty urinary bladder, and you have to patient to be relaxed 3 to 5 minutes before measurements, and you have to take 3 measurements at least 1 minute interval between each measurements, and the use of average of at least 2 measurements. So this is a classic way to measure the blood pressure in office measurements. And here from the European Society of Cardiology, it is recommended that diagnosis of hypertension should be based on repeated office blood pressure measurements on more than one visit, except when hypertension is severe grade 3, and especially in high-risk patient at each visit, 3 blood pressure measurements should be recorded 1 to 2 minutes apart, and additional measurement should be performed if the first 2 readings differ by more than 10 millimeter mercury. The patient blood pressure is average, at least blood pressure reading. And this is class 1 indication level of evidence D. It's not recommended to treat the blood pressure without assessment of global risk assessment. We are treating the hypertension as a hypertension, but if you want to treat the patient, you have to treat all the risk factors. And this is the concept of global risk assessment, because if you will treat hypertension and you achieve the goal of systolic and diastolic blood pressure, and you are leaving the patient with uncontrolled diabetes mellitus, uncontrolled lipid profile, so definitely this is the residual risk, and the patient, he can develop cardiovascular event if you will not treat diabetes to goal or hyperlipidemia to goal, and even if the blood pressure well controlled. So this is the risk factors. Our patient he is male and a smoker, total cholesterol high and overweight, and there is family history of coronary artery disease, premature, and sedentary life. So we consider our patient is high-risk hypertensive patient. And this is hypertension mediated organ damage, like asymptomatic hypertension mediated organ damage, arterial stiffness, blood pressure more than equal or more than 60 millimeter mercury, carotid femoral difference in the pulse wave velocity more than 10 meter per second, and ECG should be like our patient, LVH, fulfilling LVH criteria, and echocardiography also showed concentric left ventricular remodeling, microalbuminuria for kidney damage, moderate chronic kidney disease with GFR 30 to 59, ankle brachial index less than 0.9, and advanced retinopathy by fundus examination. So in our patient, there is LVH, which was documented by 12-lead ECG, and there is microalbuminuria, so there is 2 organ damage in our patient. So our patient, he is hypertensive, systolic pressure more than 50, and diastolic blood pressure more than 90, with multiple risk factors, with target organ damage in the form of LVH and microalbuminuria. And this is a basic screening test for hypertension-mediated organ damage. You have to do 12-lead ECG for the patient, urine for microalbuminuria, blood creatinine and GFR, and fundus examination. For the heart, you have to do 12-lead ECG to detect LVH according to the LVH criteria in different laws, echocardiography for assessment of left ventricular hypertrophy, and kidney measurement of serum creatinine, estimated GFR, measurement of urine albumin creatinine ratio, renal ultrasound to rule out renal arterial duplex, to rule out secondary hypertension, or if there is any documented suprarenal mass, and if there is for any suspected secondary hypertension. As regard established cardiovascular disease, like cerebrovascular disease, coronary artery disease, peripheral presence of atherosclerotic plaques in the carotid or peripheral arteries, heart failure, including the heart failure with preserved ejection fraction, and the peripheral arterial disease and atrial fibrillation. So according to the risk calculator, our patient here in a high-risk hypertensive patient. So the final diagnosis for our patient, essential hypertension with high cardiovascular risk. There is hypertension-mediated organ damage in the form of LVH microalbuminuria, family history of coronary artery disease, overweight, hypercholesterolemia, and ex-smoker. So the proper management for our patient definitely, as Dr. Mustafa and Dr. Ashraf mentioned, you have to start combination therapy from the start with lifestyle modification. If you will start lifestyle modification only, this is not recommended now according to our patient risk. So our goal for treatment effective, to get effective 24-hour blood pressure control and to minimize or to modify or to prevent versus target organ damage, reduction of total and the cardiovascular mortality, which is ideal characteristic for drug treatment for our patient. Definitely the treatment, pharmacological treatment, should be evidence-based in relation to morbidity and mortality prevention. Use once daily regimen which provide 24-hour blood pressure control. Treatment should be affordable and cost-effective relative to other agents. Treatment should be well tolerated and evidence benefit use of medication in population to which is to be applied. So here the different grade of hypertension. In high normal blood pressure, you have to start lifestyle modifications, then you consider drug treatment. But in grade 1 hypertension, a lifestyle modification, and you have immediately to start a drug treatment in high or very high risk patient with cardiovascular disease, renal disease, and hypertension-mediated organ damage. In grade 2, lifestyle modification and immediate drug therapy without delay, and aim for blood pressure control within 3 months. Grade 3, hypertension, lifestyle modification, immediate drug therapy treatment in all patients, aim of blood pressure control within 3 months. So in our patient, it's not enough to start lifestyle modification. You have to start lifestyle modification with immediate drug treatment, and it is recommended to start the combination therapy from the start with lifestyle modification. This slide was mentioned by Dr. Mustafa first, then Dr. Ashraf. I will not go through, and this is the summary of this slide. You have to start by dual combination first by ACE or ARBs plus calcium channel blockers or diuretics. Then the second step, if we are not reaching the goal, triple combination, ACE or ARBs plus calcium channel blocker plus diuretic. And the third, which is a triple combination plus spironolactone or other drug for treatment of resistant hypertension. So in our patient, we will use ACE or ARBs, as Dr. Mustafa mentioned and Dr. Ashraf. And also all this meta-analysis, 3 meta-analysis showed the ACE inhibitor better than ARBs, not for control of blood pressure, because both drugs, if you will use it for control of blood pressure, it will control the blood pressure. But there is benefit beyond blood pressure control, which is target organ protection. And this is proved by ACE inhibitor if you compare it with ARBs. Mainly data came from accomplished trial, ASCOT blood pressure arm trial, advance, as Dr. Ashraf mentioned, and a HYVE trial using Perindopril and Indapamide as a combination therapy. And this is effect of ACE versus ARBs for composite outcome: cardiovascular death, myocardial infarction, stroke, all-cause death, new heart failure onset, and new onset diabetes mellitus. And you can appreciate here ACE inhibitor better than ARBs for reduction of all this composite endpoint or individual endpoint with significant p-value. Which ACE inhibitor? There is a lot of ACE inhibitor available in the market, but if you will look for all this data, ASCOT advance, from ASCOT trial, advance, HYVE, ALLHAT, and all this trial, the ACE inhibitor, which is proved to be effective, which is Perindopril, and the other medication, which is Indapamide, according to the outcome data from advance and from HYVE trial using Indapamide. So management strategy of our patient, we decided to start and to concentrate about lifestyle modification and pharmacological treatment. And according to all this data I mentioned, Dr. Mustafa and Dr. Ashraf, Perindopril was the first drug of choice, and we use the small dose combination 5 milligram Perindopril plus amlodipine 5 milligram. And for dyslipidemia, we started atorvastatin 20 milligram. So Perindopril amlodipine was initiated, and this is a recommendation from the European Society of Cardiology 2018 and the European Society of Hypertension. Prescription of an appropriate therapeutic regimen is crucial. This might be achieved through using long-acting ACE and calcium channel blocker, and this came from Perindopril, amlodipine, and Indapamide. ASCOT trial showed significant. ASCOT trial is comparing the Perindopril, amlodipine versus beta blocker and thiazide, and if you will compare the outcome as regard target organ protection, the Perindopril, amlodipine arm showed 13% reduction in heart failure, 13% reduction in renal impairment, and 23% reduction in stroke for patients who are treated by Perindopril amlodipine if you compare it with a beta blocker and thiazide. This is 2020 International Society of Hypertension guideline. And the most important concentration from this slide, that in patients who started the small dose Perindopril and amlodipine, and they still, if the patient not achieving the goal, it is recommended here to increase this combination to the maximum before going to the third drug combination to control the blood pressure. Actually, our patient was not controlled on 5.5, so we increased the ACE inhibitor to 10 milligram with calcium channel blocker 5 milligram, and his blood pressure, according to this recommendation, was controlled. So in conclusion, hypertension, a well-known risk factor for cardiovascular disease. Hypertension is a modifiable risk factor. Global risk assessment, it's mandatory. Lifestyle modification, cornerstone in all stages of hypertension. Early pharmacotherapy is essential, especially in patients with multiple risk factor and hypertension mediated organ damage. Achieving a blood pressure target is a great success. Combination therapy for most patients, it's a mandatory. Single pill combination better than multiple drug combination therapy for treatment of hypertension. Thank you so much for your attention.
Can you stop sharing? Thank you very much, Dr. Maqsood. Now we can go to the questions and then we will summarize. So I think by the conclusion of Dr. Abdul Maqsood as well as Dr. Ashraf that they made a lot of answering a lot of questions. But still we will re-emphasize some of the questions just for the audience who may be coming late or who did not listen to the combination. To the combination therapy from the beginning. Now, the last slide from Dr. Abdul Maqsood said that he gave you a slide comparing ACE inhibitor or ARB. There is a lot of questions saying which is better, ACE inhibitors or ARBs to combine it with either diuretics or calcium channel blocker. To start with, which one is the ACE inhibitors? What is the best, ACE inhibitor or ARBs as the first drugs to be combined with others? Dr. Ashraf, just quickly.
Actually, all of the guidelines recommend to start with ACE inhibitor, and there are certain reasons for that. As we have mentioned, the upregulation of bradykinin and the evidence-based medicine as regards the favorable outcome as regards the mortality rather than the effect on the morbidity. But if there is contraindication or intolerability among using ACE inhibitor, then we can shift to the AT1 blocker.
Right. Thank you very much. I think you answered the question very nicely. The number one ACE inhibitors. Those questions who comes to me related to the losartan versus Perindopril, losartan versus others, valsartan, etc. So the core treatment to start with is ACE inhibitors. Then,
yes,
as the first line, but if you will, we are talking about the combination from the beginning. Then the question is it the diuretics combination with ACE inhibitors or the calcium channel blocker with ACE inhibitor? So the answer from accomplished trial that yeah, calcium channel blocker and ACE inhibitor. And then whenever the ACE inhibitor is not tolerated for any other reason, then angiotensin receptor blocker will be the alternative, and with the calcium channel blocker again. So diuretics will be the second line. Somebody asking a question about the diuretics here. He said, what about Lasix? Lasix, Dr. Abdul Maqsood, do you want to comment about the Lasix as an antihypertensive?
Yes, actually, Lasix is a good medicine for any patient who presented by heart failure with hypertension. But in essential hypertension, there is 3 diuretic therapy which prove to be effective, which is first one, which is chlorothalidone, which is not available here in our area. Second, the Indapamide. But Lasix, it is not recommended to be a treatment of hypertension. We can use Lasix for treatment of heart failure if there is in acute stage. But for long-term treatment of hypertension, chlorothalidone and Indapamide, it is recommended to be diuretic therapy for treatment of hypertension.
Okay, that answer the question, but at the same time, there is some more question related to what the diuretics. We said calcium channel blocker with ACE inhibitor, but if ACE inhibitor is not tolerated, then calcium channel blocker with ARBs. Then we come to the Lasix. Lasix has no rule for as an antihypertensive medication and never been on any guideline. If you are going to use the diuretics with the ACE inhibitor, then you are between indapamide and hydrochlorothiazide. And in fact, indapamide better than hydrochlorothiazide. But indapamide is thiazide like diuretics, and then with the small dose, you can build up the dose. The second question here that the second question is related to the left ventricular hypertrophy. and uses of calcium channel blocker combination with ACE inhibitor or beta blocker. Dr. Ashraf?
Actually, the evidence-based medicine have showed that the combination of ACE inhibitor in the reduction of left ventricular hypertrophy, and especially Perindopril, we have evidence in that, and the mechanisms are clear. So in this case, in patient with compelling left ventricular hypertrophy, I should use the ACE inhibitor, and specifically Perindopril has its molecular action as regard left ventricular hypertrophy, as well as vascular remodeling and the reduction of the media size in comparison to the lesion.
Great. So I think that's satisfied answering the question. Then in the same context, so we summarize again, ACE inhibitor number 1, and then if you combine with it, it should be calcium channel blocker, not diuretics. Still diuretic can be used in the combination or in isolation. And if diuretic will be used, try to use indapamide or hydrochlorothiazide, or chlorothalidone, in fact, as Dr. Abdul Maqsood said. But if it is at that available, then indapamide or hydrochlorothiazide. Then the next question that the LVH is good, will be responding to tissue ACE like Perindopril. And the same question now, if the person has the cough, somebody asking three questions, in fact, I have about cough. So the cough, you have to be sure. If you tell the patient that the side effect of the drug is cough, he's from tomorrow will come and tell you that I have cough. But you have to know whether the cough because of the bronchial asthma, the patient has a hypersensitive airway, or the cough as a side effect of the drug, or the cough as a heart failure presentation. One question here regarding the cough, he said about the night cough, which is, could it be from the drug or could it be from the bronchial asthma? So you have to take a history very carefully here, whether the patient has asthma or he has the side effect of the drug, or it is a heart failure and the manifestation of the heart failure is a nocturnal cough. So very important to take this detailed history. However, the cough related to the drug usually in a very small proportion of patients, and it is in the throat. The person will feel something in the throat irritating him and he will cough. Any further comment in this issue, Dr. Abdul Maqsood?
Yeah, I agreed about you have to take good history and analysis about the cause of cough, and if there is any underlying cause can explain the cough, so this is most probably the cause of cough. But most of the patients, they tolerate the ACE inhibitor well, and in our daily and real world practice, this side effect only involve a small number of patients, not all patients. So you have to take a very good history to be sure 100% there is no other cause of cough before discontinuing ACE inhibitor. Actually, in the cardiology field, you know, ACE inhibitor for us, it's a cornerstone like beta blocker in coronary artery disease and heart failure. So we are concentrating about and insisting to convince the patient about the benefit, and definitely we will do good analysis about the cause of irritative cough.
Thank you very much. I think to be fair for the audience, one person asked, what is the contraindication for single pill combination? In fact, the relative contraindication, or not really a contraindication, it is be careful with elderly people and using the combination in the maximum dose. But if you will use the combination in a smaller dose, the HIFIT trial introduced by Dr. Abdul Maqsood and Dr. Ashraf, they showed you that in elderly people, the HIFIT trial combination Perindopril and Indapamide was safe. There was no significant postural hypotension, and there was no complication of syncope. So the combination can be used. You have to be careful with elderly and use the appropriate combination if the person at older age, 80s or more than 70. So that's the only concern. Otherwise, there is no contraindication. You can start. So one person said, asking a question here, he said that should we start the single drug or monotherapy to the maximum, then we go to the next, or from the beginning we should combine. I said the whole guideline these days, according to what have shown and Dr. Ashraf, Dr. Abdul Masood, we prefer a single pill combination from the start, and it should either be slow dose or high dose. Another question is that is said about the losartan with the chest infection. Anybody with anything losartan or the best drugs are ACE inhibitor. If the ACE inhibitor is not tolerated, then you can use any ARB. ARBs and ACE inhibitor can be used with any chest infection, but you have to be careful. If the person is very clearly asthmatic, then probably bradykinin, which is a very protective molecule, may be increased, and it can irritate and cause cough sometimes if the person has significant hypersensitivity airway. Is that correct, Dr. Ashraf?
Yes, I do agree, but I have noticed, Dr. Mustafa Bey, in the combination of Perindopril and amlodipine, there is less liability for cough, and I don't know why, but it is a finding. This happy combination minimizes the cough induced by ACE inhibitor. But I totally agree with your opinion in this point.
Thank you very much. Dr. Abdul Masood, there is a specific question about the kidney function. One question said, what is the best combination to start in patient with chronic kidney disease? One patient chronic kidney disease without dialysis, and another patient with resistant hypertension and dialysis. One without dialysis and one with dialysis. What is your starting treatment for these two patients?
Yeah, actually, the most safest drug for treatment of hypertension with chronic kidney disease, the calcium channel blocker. So we will start by calcium channel blocker. And all of us, we know that the ACE inhibitor and even ARBs are renoprotective drugs. So the combination should be initiated as ACE or ARBs with calcium channel blocker. And for better assessment of renal function, you have to check the serum creatinine, and if there is elevation of the creatinine more than 20 or 25% from the baseline, so in this situation you can hold the ACE inhibitor and continue the calcium channel blocker. Also, in this group of patients, you have to take care of serum potassium as a baseline.
Yeah. So basically, the calcium channel blocker plus the ACE inhibitor can be used in chronic kidney disease in the early stage as a protective effect for reducing blood pressure, and you might improve the kidney function. Yes. But you have to open your eyes for the hyperkalemia and the deterioration, further deterioration of the creatinine. But still, they are important drugs. In the same context, Dr. Abdul Masood, one question here came that I have a patient with 145/80. Then should I use a combination if I want to reduce his blood pressure to 130/80 or less?
Actually, it depends upon the age of the patient, and if there is associated diabetes or left ventricular failure or coronary artery disease. If young patient and the blood pressure 140/80 without any compelling indication, so in this situation we can use according to the recommendation of guideline, single drug, not combination. But if there is heart failure or coronary artery disease or diabetes, so our target to keep the blood pressure, the lowest tolerated blood pressure, so better here to start a combination therapy to achieve the target in patient with diabetes, coronary artery disease, or heart failure, and to keep the blood pressure the lowest tolerated systolic and lowest tolerated diastolic blood pressure.
So if I make a comment at this, the GNC8, they said if the blood pressure is more than 20 systolic than your target, 20 systolic more than your target, the combination therapy is the way to go. Yes. For example, the example our colleagues made here, that 145 blood pressure, if I give a combination, I am going to reduce it 20 millimeter mercury. So I will come to systolic blood pressure of 125. That's within the guideline of the Canadian and American. So I think you can still use the combination, but the only consideration, as you have said, the age, but still in the age, HIFID trial has shown that the combination of the Indapamide and the Perindopril was safe. So you have to consider the age, consider the kidney function, and consider the patient symptom and the blood pressure. So in this case, I think still you can use the combination, but in a smaller dose. Here the question, maybe Dr. Ashraf said a question was not clear to me, but he said how to, what is the role of maintaining the blood pressure? How we should maintain the blood pressure within the target? Dr. Abdul Maqsood, you are
sorry.
have mentioned that there are certain players in
دكتور أشرف تفضل.
عمر مع حضرتك.
السؤال اللي سعادتك انه كيف how to maintain the blood pressure control in general.
Actually, by by adopting the new adherence to the recent guidelines by the single knee in order to maximize the arms of the pathogenesis of hypertension as much as we can to increase the confidence of the patient, increase the awareness of the patient about the risk of hypertension by adopting the proper lifestyle, by the proper medication. Our first choice is matter as regard to bring the patient as early as possible into control.
Great question. Now the question to Dr. Abdul Maqsood. If your patient is a black patient or African American, how you will approach him?
Okay, so I will approach the patient, but I will start by calcium channel blocker as a first line treatment, beta blocker, and if the patient not controlled, I will use the ACE inhibitor combination to achieve goal. So it may be the arrangement which medicine to start with. But if the patient black or African American and you have to start with a calcium channel blocker, small dose beta blocker with diuretic therapy, and it is recommended either to use hydrochlorothiazide, chlorothalidone, or indapamide.
Okay, but if we now here I will make a controversial with you as usual. Yes, we will fight here, but yeah, tonight I am feeling that Dr. Ashraf will support me. First of all, that the combination can be used in any patient regardless of their race, whether the calcium channel blocker or with the ACE inhibitor. This is number one. Number two, whatever the drug. But the question is that you might find the tissue benefits of ACE inhibitor in black, and then but the blood pressure might not responded well to the ACE inhibitor. So if you combine, for example, calcium channel blocker and ACE inhibitor, you are going to have one, the blood pressure control, two, the benefit of the ACE tissue ACE.
Yeah.
Similarly, similar to heart failure patient, we know the heart failure patient might not benefit from the ACE inhibitor in lowering the blood pressure, but the benefit, you still need to start with ACE inhibitor in every patient, whether they are black or not black, and that's because you need to improve the endothelial dysfunction and you need to improve the tissue factors. Dr. Ashraf, you will support me ولا هتتعاون؟
Yes, for sure, for sure. لا agree يا دكتور مصطفى لان
الصوت مش كويس قوي يا دكتور عبد المقصود.
شفت بقى يبقى الصوت معايا انا.
الصوت مش واضح.
نون هيموداينامكس زي ما حضرتك كده.
ضع السماعه على السماعه دكتور اشرف. استخدم السماعه كويس لانه مش سامعينك. على العموم خذلني الصوت ولم يخذلني الدكتور اشرف. تفضل يا دكتور عبد الباسط.
Yeah, actually, if there is any compelling indication to use ACE in Black or African American, it's indicated to start ACE or ARBs in Black for treatment of hypertension, mainly if the patient have coronary artery disease, heart failure, or unstable angina or post-MI. Definitely, there is indication. We are not saying that it's not working in Black or in white. It can work and it's indicated, and a lot of African American and Black, they are receiving ACE inhibitor and calcium and the ARBs for treatment of hypertension and for treatment of hypertension with heart failure, hypertension with coronary artery disease, and post-MI patient. Definitely there is indication and no difference between all drug groups to start with for treatment of hypertension.
التايم هو لا 9 ولا 9:30.
والله يا باشا احنا سعداء جدا وانا عايز ساعه
هو
كمان.
لا انا عاوز ساعتين بس. السؤال هو التايم بتاع الزوم كم؟
اعتقد 9. بيقولوا 9 اعتقد.
اوكي اي ثينك وي ار. عشان كده الدكتور اشرف اختفى صوتا وصوره. I think we answer most of the questions. However, there is some question we might address later on. And the more frequent question about really CME and then entering the CME to the system, etc. This is Saudi Heart Association will take care of it. But we are really happy tonight that Dr. Abdul Maqsood with us and Dr. Ashraf, they highlighted a lot of information in the different phase of the hypertension. We are not talking about hypertension as hypertension, but hypertension with optimum and quality of care. And we emphasize that ACE inhibitors with the indapamide is an important for the mild hypertension or mild to moderate. Then if you go for high blood pressure, you can go for combination of Perindopril and ACE inhibitor as a first line combination therapy. And we explained that is the advantage of all of those. And I am happy with the audience who's about, they reach the level of 2,000, mashallah. And then the questions, in fact, they support and it makes the meeting is fruitful because of your question. Some more question is there, but unfortunately the time is not in our favor. And already Dr. Abdul Maqsood اختفى صوتا وصورة فنعتذر للجميع.
انا موجود معاك يا باشا.
دكتور أشرف already disappear by pictures and by the sound. شكرا يا دكتور عبد المقصود. شكرا للدكتور أشرف. شكرا للشركة المنظمة Survey for supporting this important meeting and Saudi Heart Association. تفضل يا دكتور عبد المقصود.
شكرا جزيلا. يلا باي باي. السلام عليكم.
شكرا عليكم السلام.